Welcome to Advancing Health. Patients grappling with substance use disorders can get temporary care within a hospital setting, but where is the continued support after discharge? In this podcast, we learn about one answer to that question. It's called the Bridge to Care Collaborative.
My name is Jordan Steiger, and I am the AHA Director of Behavioral Health and Violence Prevention at the American Hospital Association. I'm joined today by Dr. Heidi Bray, who is a nurse practitioner and hospitalist at Providence St. Hospital in Olympia, Washington. Heidi serves her patients and her community through working at a community-based, peer-led, low-barrier Suboxone program where she provides outpatient MOUD care or medication for opioid use disorder and works with the team to refine clinical pathways. I'm really excited for this conversation today because I got to meet Heidi through the work that we are doing through a CDC-funded project here at the AHA through our Health Research and Educational Trust called the Bridge to Care Collaborative. And what we are trying to do in this collaborative is improve the pathways, improve linkage to care, and improve retention in care for patients with opioid use disorder and stimulant use disorder specifically. But we do know that all of the work we're doing can really help patients across the care continuum that have substance use disorders. So Heidi, thank you so much for joining us today.
Of course, my pleasure.
Before we get into the details of the work we've been doing together, I would love if you could just tell us a little bit more about the community you serve at your hospital and just kind of where you're from.
Sure. So I am a Olympia, Washington native, and I have the privilege of serving and caring for patients in the community where I grew up. Providence St. Hospital is part of a larger system, Providence Healthcare, which extends over 5 states in the Western United States. We are a faith-based Catholic hospital system that has a rich heritage and culture based in a deep history based in our community of over 150 years of caring really for the most vulnerable patients in our communities, and serve a 5-county area. So we have a large geographic catchment, which is part of our challenge as we seek to adapt to a changing healthcare system and changing realities in both our suburban and rural communities.
Absolutely. And that's a great overview to get us started. And, one reason I'm so excited to have you here today is because you have that hospital perspective, but you also have community perspective. You serve a largely rural population across a very large geographic area, even though you're located in more of a suburban, larger city setting. Is that right?
Correct. Our setting is in sort of a mid-sized city, but we draw from the surrounding counties, accepting in transfer patients from smaller rural hospitals and facilities that either don't have capacity or ability to handle certain patient demographics. Complex patients requiring infectious disease consultation, neurologic consultations, oftentimes surgical consultations, cardiac consultation, that kind of thing come to us. And oftentimes those patients have layers of substance use disorder as well. So these are patients that may be out in rural counties where there is one small 20-bed hospital and a dwindling number of outpatient resources, certainly very limited resources for substance use disorder care, who come to our hospital with a multitude of needs. And so we try to manage those as optimally as we can in the acute care setting, and then figure out, pertaining to our work with the AHA, how do we link those patients back to their community, to their home, to their families, and still keep the ongoing important aspects of their care intact so that they can live well. And that's a particular challenge with substance use disorder.
Thinking about some of maybe those specific challenges, you mentioned comorbidities that might bring people into the hospital, and then they also have a substance use disorder. And let's say the patient gets the treatment they need, they're ready to go back to their families and their communities. What are the challenges that they face as they're making those transitions?
So let's say we have a patient who maybe came to us in transfer from a small outlying rural critical access hospital, where they were admitted and there was a high level of concern for a complex infection, maybe in a joint or heart valve. And they are transferred to our facility where they undergo whatever surgical consultation is needed, whatever infectious disease consultation is needed. But we know that this patient was placed at risk for this infection because of their substance use disorder. They may be with us for a number of days, even weeks, while we sort through the acute critical problem. And optimally, we transition them to MAT for their opioid use disorder. And now we're preparing to discharge them back to a community that doesn't have anyone who prescribes Suboxone or methadone. And what does that look like for this person? So figuring out issues of, say, transportation into a larger center of care where they can come, monthly for their medication management. Sometimes that's interwoven with telemedicine opportunities that many of our community partners also offer. We are blessed to have rich tribal resources in our Northwest communities where the tribes are really doing great work around growing access to care, both primary care and substance use disorder care, and oftentimes have transportation support available to their patients as well. And many times they very generously serve patients who are not affiliated with the tribe. So we're able to connect people to their services, which is wonderful. But all of this takes a lot of care coordination, a lot of connection, a lot of knowledge around what resources exist so we can support patients. I think what's really tragic to me and really continues to be tragic to me is that, quite honestly, it's easier to purchase drugs in many of these outlying communities than it is to get access to good healthcare that serves people with substance use disorder. And until we address that underlying problem in our communities, this will be an ongoing challenge for these patients because, quite honestly, it's easier to find some fentanyl, purchase fentanyl, than it is to, in many cases, than it is to stay engaged with a provider who can continue to help manage your chronic disease of substance use disorder with MAT. So we need to shift that narrative in order to really succeed.
I know one thing I've come to know about you in your professional life is that you're really passionate about access to these medications to help with treatment. And you've been doing a lot of work through this collaborative to educate your fellow providers about how they can prescribe.
Sure. Well, the AHA Collaborative Project has been really a gift. What the opportunity has given me is some time and some connection with other providers and communities and systems across the country through the AHA Collaborative who are struggling with the same issue. The issues have a different flavor in different communities, but they really, at their core, are the same. And so I practice as a nurse practitioner. Certainly, I have one foot in the nursing tradition and one foot in the medical world. I practice as a medical provider in my facility, but I am very connected to our nursing staff and very interested in figuring out how we collaboratively across nursing and medicine serve these patients, because these patients require that. They need it. They need us all to bring our best game forward. So I have approached this problem to date a couple of ways within the AHA collaborative work. First is that we decided to focus at the bedside, which is we have a number of passionate clinicians, providers, prescribers in our facility who are open to and engaged with this patient population and work diligently to transition patients to MAT while they're in the hospital. We have bedside nurses who have relative inexperience with these medications. And so what I have found is that I can work together with a patient to develop an induction plan that's fairly complex. Sometimes getting patients off of the medications we've been managing pain with in the hospital and transitioning them successfully to, for instance, sublingual Suboxone is a fairly complicated several-day process. I can put all those orders into our EMR and then find that the bedside nurse is really perplexed by this medication, perplexed by this process, perplexed by cross tapers and taper plans and coming off of when do I give the opioid, when do I give the Suboxone, and even more importantly, how do I educate a patient who's never taken a sublingual medication? I'm handing them this strip. What do I do? after innumerable opportunities to do one-on-one coaching with bedside nurses, I realized we need to just do a house-wide education. Identified a RN in our facility who was working on her master's in nursing and education, and she was seeking a clinical project, an education project. And so we've partnered together to develop some teaching tip sheet for our bedside nurses that we are rolling out with a presentation to our nurse educators across the facility, and we'll be reaching every nurse at the bedside with just some specific clinical information in how to administer sublingual Suboxone as a place to start, as buprenorphine as a place to start. And I'm hoping what this will do, because in my experience, this is what happens, is you put out some clinical pearls, some tidbits, and it really starts a larger conversation about, wow, we have a tool that we can use. And so how does this tool start a conversation? Not only with nursing, but with patients, starts that dialogue around teaching and coaching, gives nursing, bedside nurses the confidence to have that conversation. And then also, I hope, will help our biggest cohort of providers in the hospital, the bedside nurse, as they see this strategy work with their patients. I'm hoping they will also push hospitalists and family medicine providers who may be a little reluctant or maybe hadn't thought to address this issue with the patient.
I love that you're bringing in learners. I love that you're creating advocates across your organization through, nursing, staff at the bedside, seeing that this works and seeing that it helps patients. I think these are all amazing examples. And I think, creating the learning materials that you mentioned is a great example for others on, listening to this podcast.
And it's fun to work with learners in this space because when, in this case, even better because it's a learner who I also work alongside in the care of patients. And she and I had actually cared for a patient with opioid use disorder. She is an orthopedic nurse on her floor. And so I think that piqued her interest when she saw the shift in the therapeutic relationship with this patient when we were able to step away from the angst around when is my next oxycodone dose to, I'm actually feeling pretty good on this buprenorphine. And wow, all of a sudden it extracts the angst and the time clock watching and the sort of edginess of that relationship that can develop between the bedside nurse and the patient who has legitimate pain and substance use disorder. And if you remove that discomfort, that conflict around the PRN opioid dose and replace it successfully with scheduled MAT, you open up space for the real therapeutic work that nurses want to do. They want to talk to their patient about how to adapt to the injury that they had or the surgery they just had. Those are the things that everybody thought they were getting into bedside acute care nursing to do. It really lights fires when they see the restorative nature of creating space for those conversations with their patients and just an honest conversation about substance use disorder. I mean, this is a cohort of patients that they come to us not trusting us. And yet, when you build a little bit of trust and open the door, they'll teach you all kinds of things. You learn about your community. And, we live and work in this community, and we have found a way to put our blinders on as we, drive through town to the suffering that happens in our sidewalks and our forests where many are living. I think to come to understand that and open the door to understanding it with the patients we care for at the hospital is really enriching and important for both sides of that relationship. We need to understand their life better, and they need to understand that we are kind and that we have something to offer to improve their wellness as a stepping stone to potentially improving their overall circumstances.
As you were talking, even before you said it, the first word that was coming to my mind is trust. And trust is going to help those patients know that we have their best interest in mind, and we're going to send them to the next level of care and keep them going on a path that's good, that is going to help them get to their goals. I think that is a great place to end this conversation. And I just want to say thank you so much again for being here and really bringing this topic to life for our listeners in a different way.
Of course, Jordan, my pleasure. It is. This is the most gratifying patient population to take care of, I think.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.